Hello everyone, welcome back to A to Z Dentistry. Let's continue about the post-insertion problems in complete denture patients. As we have already covered about the denture assessment in part 1 and major problems related with newly delivered dentures in part 2 with its cause, diagnosis and treatment for each type of problem, let's discuss about the common and uncommon problems related with dentures, its cause and treatment. As described in part 1, the post-insertion problems were classified by Shari as common and uncommon problems. One of the common complaints faced during insertion of the denture is nausea and gagging. Nausea and gagging is seen in patients with an exaggerated gag reflex. It may also be caused by the overextended posterior extent of the maxillary denture and the distal part of the mandibular denture. In such a case, the denture should be reduced posteriorly to the posterior palatal seal area. And it may also be caused by unstable and poorly retained dentures. Gagging can be classified as two types, psychogenic and somatogenic. Psychogenic starts within the patient's mind itself without any initiation, and it is very difficult to treat. Somatogenic has its initiation from the body, that is, denture or any dental procedure can initiate the feeling and it is treatable. It can be due to dental reason also, that is, overextended denture base in posterior palatal seal area, poor occlusion, lack of retention or excessive vertical dimension can cause gagging. The treatment is by determining the cause whenever possible and remove all biological and mechanical factors that may contribute to the problem. Prescribe a combination of hyoscine, hyoscamine and atropine with a sedative during the initial period of denture use. Acupuncture, that is auricular acupuncture, is used for treating severe gag reflex, and the role of acupuncture as a method of controlling the gag reflex is very safe and quick. Next is the difficult deglutition. Pain during swallowing is often caused by overextended peripheral extension such as an overextended posterior palatal seal area or overextended retromylohyoid flange and compression on the superior constrictor. This may also be caused by an increased vertical dimension. Reducing the overextension or the vertical dimension should solve the problem. Other problems related to overextension or the vertical dimension are pain on eating, pain or inflammation in the labial aspect of the lower lip, pain about the periphery of the dentures, etc. Pain on eating in presence of the occlusal imbalance is because of anterior or posterior prematurity, incisal locking or lack of balanced articulation. Determine the occlusal prematurities and adjust occlusion by selective grinding is the treatment. Pain or inflammation on labial aspect of lower ridge is due to lack of incisal overjet causing incisal locking, which is treated by reducing the incisal vertical overlap, and if appearance is compromised, resetting the incisors may be required. Pain about periphery of dentures, possibly accompanied by pain in masseter and posterior temporalis muscles, which tends to intensify as day progresses, is due to the vertical dimension of occlusion more than the patient can tolerate. Coming to the temporomandibular jaw problem. They occur mostly due to spasm of muscles of mastication or injury to the muscles or to the surrounding structure. These types of problem usually seen in patients who were long-term wearers of complete denture, that too with much amount of loss of vertical dimension of the occlusion. If this problem is not treated at time, it will lead to some other serious complications like referred pain to ear, TMJ, muscles of mastication, clicking sound in TMJ or crepitus, tinnitus in ear, pain during opening or closing of jaw, midline deviation or shift during opening. The primary goal of treatment is to treat the underlying cause of the problem. If related to vertical dimension, new set of complete denture with correct vertical dimension should be made again, and patient should remain on soft diet for a specific time period. Hot packs are advised over the area where pain is persistent, and muscle relaxants should be advised to the patient. Food accumulation under dentures. Food accumulation under the mandibular dentures could be minimized by correct position of the tongue by the patient. Wright and co-authors suggested that the ideal resting position of the tongue is to keep the apex of tongue in proximity to the lingual surface of the mandibular anterior denture teeth, with the lateral surfaces touching the posterior teeth of the denture. The less adept the patient is in stabilizing the processes during function, greater will be the denture movement, and greater the quality of food particles that would collect beneath the dentures. Unilateral chewing causes greater denture movement, so bilateral chewing is recommended for the complete denture wearers. Next is dislodgement of dentures on taking fluid. This problem may occur when dentures are first worn by the patient. The patient should be informed that it is possible to experience loosening of dentures while taking fluids or for initial few days. A patient may get used to it when lips, cheeks and tongue learn to manipulate the dentures. Saliva under dentures. Stimulation of the salivary glands of posterior palate may cause increased salivation in the initial period, and through practice it reduces and the patient gets used to it. Nature and the type of saliva has an important role in the retention of complete dentures. Next is the altered taste sensation. Dentures do not cover many taste buds. Thus no physiological basis for this complaint. Thickness and low thermal conductivity of the acrylic denture-based material could be one of the cause. This is managed by decreasing the palatal cover as long as retentive forces are deemed adequate. We can give cast metal plate which conducts heat and cold sensation, which in turn enhances the taste sensation. Due to atrophy of taste buds in the old age, patient might suffer from taste loss sensation, and in most of the cases it is psychological. In such cases you can encourage to have flavored food. Peculiar taste sensation can be due to poor oral hygiene, and for avoiding such peculiar taste, the patient should be educated how to maintain a good oral hygiene. Halitosis. Halitosis is usually associated with bad oral hygiene when patient is not cleaning his or her denture for a long period of time, and may lead to bad breath, or it may be due to medically compromised conditions. Drooling of saliva at the corner of the mouth is another uncommon complaint, usually seen in patients with poor muscular control, where there is closed vertical dimension of occlusion, and in cases of hypersalivation. Treatment modality should be to treat the underlying cause if this occurs due to decreased vertical dimension of occlusion. New denture should be made with correct vertical dimension, and an other attempt should be made to control the drooling of saliva at the corners of the mouth by making the denture flange a bit thicker at the modulus area. This problem may occur due to a decreased vertical dimension, and an attempt should be made to correct the vertical dimension. Also, if the vertical dimension is correct, then an attempt should be made to increase the thickness of the flange in the modulus area. Tingling and paresthesia. This problem may be seen in excess resorption leading to the mental phenomena involvement near the crest of the mandibular residual ridge, and if no relief is provided, then tingling and mild paresthesia of the lower lip may occur. This may be recorded and relieved to eliminate the problem. A similar situation can occur in maxilla from the pressure on incisive papilla due to the compression on the nasopalatine nerve. The patient may complain of burning or numbness in the anterior part of the maxilla. Relief may be required in the maxillary denture base in this region. Clicking sound while eating. This is caused with overextended complete dentures and due to premature contacts or excessive vertical dimension of occlusion. The treatment is clinical remount should be done with occlusal equilibration, relining or rebasing in case if the fit of the denture is not appropriate. Noise on eating or speaking is because of excessive occlusal vertical dimension, occlusal interference, loose dentures. It is also found that porcelain teeth create more impact noise than the acrylic. These are corrected by addressing specific faults or remake as required. Speech problems are usually uncommon, but presence is of great concern to patient. It may be because of new tongue positions, new occlusal relationships or new teeth orientation, and it can be easily managed by ensuring the palatal contour and should not allow excessive tongue contact or air leakage. Next is sore spots. One of the most common complaints usually associated with the use of new denture. This occurs due to inadequate coverage of edentulous ridge with the denture, overextended flanges in the vestibular region, excessive vertical dimension of occlusion results in overall redness on the edentulous ridge, presence of sharp bony projections from edentulous ridge, presence of thin atrophic mucosa over the edentulous ridge, or in case of tori, if present either in the maxillary or in the mandibular region, it has to be relieved. Unfavorable patient habits like clenching of teeth, as in patients with bruxism or in tobacco chewers, etc., and due to local infections like bacterial or fungal infections, there can be sore spots seen or in the palatal area. Treatment modality will stick to the underlying cause, that is, the denture base should cover the entire edentulous ridge. Overextension of the denture base should be reduced and should be smooth, adequate vertical dimension, and it should not be excessive. Sharp bony projections should be smoothed. Tori should be relieved. Local infections should be treated with appropriate medicine, starting with discontinuing the wear of denture for at least 24 to 48 hours. Next is xerostomia. Most of the elderly patients are on multiple medication for systemic diseases, and many of these drugs are capable of causing xerostomia, which has adverse effects on the tolerability of complete denture. These type of patients have problems or difficulty in masticating or swallowing of food. These patients are advised to drink water in between the meals and should have plenty of intake of water or water substitutes. The use of artificial saliva or mouth rinses may be helpful to the patient suffering from condition of xerostomia. One can also use a reservoir at the palatal side which is filled with artificial saliva, which surely overcomes the quality of life of xerostomic patients. Silagogues are the drug of choice in treating patients suffering from dry mouth condition. They simulate the flow of saliva without affecting its dialin content. The main cause of dry mouth condition in old age patient are some drugs such as antidepressants, geriatric degeneration, deficiency of vitamin A, chronic renal disease, and psychic tension. The patient should be dealt with in a sympathetic manner, keeping in mind that such complaints are very important to patient. A careful scrutiny based on a thorough knowledge of normal and abnormal tissue responses as well as of the fundamentals of complete denture processes is essential in treating the problems connected with complete denture use. There are many ways that dentures can be improved, and dentists should be able to assess the quality of a denture in terms of aesthetic, support, retention, stability, occlusion, vertical dimension, and extension of denture base. In the next part, we'll discuss in detail about the sequelae of complete denture wearers in detail. Thank you.